So today we're here to talk about the Care Home Liaison and Dementia Outreach Service and about how we maintain mental health within the care home settings. Obviously, we've done as introductions, we'll skip over that. So when we're looking at mental health and maintaining it within care home settings, we need to acknowledge that it's just as important as meeting those physical health needs. We know that 40% of people living in nursing homes within England have depression. And actually, 50% of those develop that depression within the first 6 months of admission to care home. So it's really common that people very quickly develop that depression. And that's due to the fact that they have multiple risk factors. And equally, when we're looking at that older age population, we're looking at just under 15% of people over the age of 85 live within care homes. So it is quite significant for our ageing population. Mental health encompasses an awful lot of conditions, and within that there is dementia, which again is a big factor within our care homes. 70% of those living within the care home setting have a diagnosis of dementia, and often when people have dementia, communication can present in a number of ways which impacts on behaviour, which is often then classed as a mental health problem, and where the care home liaison team and the dementia outreach services come in. But what we need to acknowledge is that these are all forms of communication driven by need. One of the key things that we often see, be it dementia or another mental health condition, is distressed behaviours. And actually, what I'd like people to do is just, if we think about how distressed behaviour presents and why it happens both within ourselves, within family and colleagues around us, and some of the things we often see, it tends to be that actually people are, when they're distressed, they're a little bit more hostile, a little bit more brittle. They're perhaps a bit more irritable. They tend to be tapping a lot. We all have those colleagues that tap, tap, tap at the desk when they're getting annoyed and things like that. We have family members who we know when they're tired, they're a little bit grumpy. I've got a preteen. We know when she's tired, she's incredibly grumpy and moody and snappy the day after. We still see these sorts of behaviours when we're looking at people within care homes. And it can be down to a number of reasons. And equally, people become withdrawn, people become less engaged. So these things are normal things that present anyway. For those of you that work in care homes, what we'd maybe like you to do is perhaps sort of share within the chat of some of the things you've seen around distressed behaviour and challenges in your own professional settings, and perhaps sort of share some of those success stories of how it was managed. Because I think that's always key. If we share our successes, other people can learn from them. But those distressed behaviours, if someone's distressed, it's often because they are trying to communicate something that they're unable to express. And there can be numerous reasons for that. People can be feeling disorientated and frightened. And especially if we're saying that 50% develop depression or behavioural symptoms within 6 months of moving into a care home, it is often because they are disorientated, they are frightened. They may not recognise the place that they're in as their home. They may believe somebody is trying to harm them. If we think about, particularly with dementia, if somebody is convinced that they're a young mother, that they've got young children, they're not going to recognise their elderly children because they believe they've got babies at home. You're trying to stop them leaving that environment because they need to go pick their babies up from school. That person that's in bed next to them, that has been their husband for the last 50 years, if they suddenly start remembering their husband and picturing him as a 30-year-old, and all of a sudden he's not 30, it's a strange man that's in their bed. They want to go home, they want to go to a place that they feel familiar with, and that's often something that's historic. And in fairness, we'd all be a little bit distressed if we thought there was a strange person suddenly laid next to us in bed, or somebody was trying to tell us that we couldn't go pick our children up from school, or our babies were being left alone. It can also be down to things such as visual problems and environments, and these often make things worse. Grey is the in colour these days. Everybody's house has got grey carpets, grey wall paint, grey furniture. But actually, as we get older, it's difficult to distinguish between boundaries and blurred as our lenses thicken on our eyes, and actually pale colours don't help. So having really sort of distinct door frames round doors to help distinguish these things can help. And also not having environments where people can freely move about. If they're overstimulated, if there's too much noise, if it's too echoey, it can be very disorientating and frightening. If we can't see, if we can't hear, we feel less secure in ourselves. People also get anxious and depressed, and it's often believed that people with dementia cannot experience anxiety or depression, but this is not the case. It just that often they're unable to express those feelings in a way that we feel comfortable in acknowledging, and often that can lead to a greater level of distress. Unmet needs is also a big reason for that distress behaviour. Somebody may be hungry or they may be thirsty or too hot, too cold, they could be in pain, they may need the bathroom, they may just feel a bit stiff and need to get up and stretch, they may be bored, but again have difficulty in expressing this. Changes in routine, such as hospital appointments, family gatherings, visitors unexpectedly coming into the homes, can again lead to increased in distress behaviours. And transitions in care, certainly when we're looking at care homes, if somebody's moving between residential to nursing care, if they're going from hospitals into care home settings, assessment beds or home environments into care home settings, these can often be a trigger of those distress behaviours. And again, that goes back to that feeling disorientated, frightened, anxious, those needs not necessarily being met because people don't know that individual as well as they could do because they're new to the environment. Sundowning is something we often see in dementia, and that's where the person with dementia feels more confused and distressed. It says here in the evening, but again, it can be at other times of the day, and it tends to be again linked around fatigue levels. And we have to acknowledge that people have past life events, be it they've got dementia or other mental health conditions, and they may have experienced trauma that, again, they relive those situations or certain things trigger memories of those events. And one of the other things that we often see, certainly within the care homes, is around delirium, and that's an illness that can cause increased confusion and fear and can take quite a while to resolve as well. Often we see that acute stage and think, oh, it's resolved, we've had some antibiotics, things have settled down following an infection a couple of weeks later, but actually delirium can take up to 12 months to resolve. So how does it present in those people? Often we see people that are more aggressive, they're anxious, they present with apathy, depression, agitation. People can have delusions and hallucinations. They can become very sexually disinhibited. They can become frustrated and angry, often behave out of character, this is what people describe to us, and they can become quite suspicious and paranoid. So the sort of things that you may see is people shouting, sort of maybe crying, groaning, using quite offensive language and being verbally aggressive. They can be calling out for someone. They can be asking to go home, even if they are at home. They can be behaving aggressively, that hitting, pinching, biting, and they can appear agitated, so pacing, fidgeting, trying to leave the environment, or they may become withdrawn and uncommunicative. It may be that we see people walking with purpose, so they're wandering, or they could be pacing, they could be restless, but not all walking with purpose is restlessness. Sometimes people are just walking and quite happy walking. Or it can be that they're trying to get up out of bed, out of chair, so they're not getting rest when they need rest. Often, we come into people where they're not sleeping because they're getting into bed and constantly trying to get out, and then they don't get rest, and then they become more tired, and it becomes a bit of a vicious spiral. So what can we do about it? We need to be able to understand the behaviours. We need to be able to ask them and see what their responses are. We need to be able to provide that purposeful activity and occupation, and we need to be able to reduce stimulation at times. We all have moments where we become overstimulated. Sarah and I'll both tell you when we've got to the end of the day of people wanting us all the time, and then we get in the house and the kids want us all the time, and the husbands want us all the time. Probably by 8, 9 o'clock, we're overstimulated and don't want to engage with anybody. Um, but clear expectations about who and what is happening and keeping them quite concise, not overly convoluted, can help. Because be it dementia or be it depression or other mental health illnesses, it can be very hard cognitively to process convoluted explanations. So clear, short, to the point, paced out examples are good ways to help with communication. Also about understanding the needs that are being communicated. Are we ruling out things such as, have we offered people a drink? Have we offered them something to eat? Have we seen if they need the bathroom? Have we engaged them in some activity? If it's really loud and it's noisy, actually, is it that we do need a quieter environment? And we'd say the key to it all is trying to stay calm, and that if safe, it's okay to consider leaving and giving people space. Have a good understanding of the individual is what is important to them, and that person-centered care is what's key in all of this. Getting to know that individual, knowing their life story, knowing their history, knowing their likes and dislikes. Is it that they prefer 2 sugars in their tea and 1 in their coffee? So what can we do about it? We can think about, are our environments dementia friendly? Because even if it is not dementia, actually those dementia friendly environments where there's things to do, where there's space, where there's quiet spaces and stimulating spaces, they're suitable for everybody and helpful for everybody. Very much like we said, knowing the person, knowing their life story, their triggers, and sharing that with staff. That routine to create a feeling of safety can be key. People often with anxiety or with dementia feel better if they know that there's a routine, if they know what's coming and when it's coming. Simple things like ensuring that glasses are worn, teeth are fit, hearing aids are in. It's so much easier to communicate and feel more secure in your environment if you can see what's going on and hear when people are talking to you. Trying to keep people orientated and giving them information and taking that time to care, which we know is never an easy one. There's always more appointments, there's always more people that need us. Um, and we all, no matter what roles we're in, struggle with time to care. Regular routines, we'd say, very much key, like we said about hydrating, toileting regimes. Pain relief is another big one. People often experience pain and struggle to express that. So again, knowing that individual, if they're feeling out of sorts and we've tried everything else, is there pain? Yeah. Are they grimacing? Are they guarding? Are they avoiding certain area, leaning on or sitting on a certain side or something? Is it because of pain? And think about unnecessary interventions. Again, if people are getting distressed and agitated, what interventions need to be done and what interventions can be left or can be left till later. Knowing when to walk away and when to try again later. And considering, like we said, the pain and the triggers, but also providing that activity and distraction. Sometimes, yes, they need stimulating. Sometimes we need quiet space. Sometimes people just need to be distracted. And certainly one of the other things is very much considering our own emotions and our distress, that are we feeding into somebody else's distress? That if we're feeling that we're having a difficult shift and there's lots of pressures and we're rushing, are we projecting those emotions onto the other person that is already feeling vulnerable? Yeah, are we being active in our communication or are we being reactive in our communication? On that note, I'm going to hand you over to Sarah.
So, one of the things we are doing is delivering the Clear dementia training package to the care homes across Bradford, Airwharf, and Craven. And this is basically what Clear is about. Look at all of me, looking at cognition, life story, and personality, emotional and physical well-being, activity and environment and relationships, And what I want to do next is for you to watch a video of some care home residents with dementia living in a care home and what it's like for them. And then on the clear bit, we'll go back with some of the examples of the staff and the patients that are in them care homes, and I'll discuss how it works. This is where we hope it works.
Yeah. Bear with me. This is where I show my distinct lack of technological capabilities.
There doesn't appear to be any sound on it, Heidi.
Right, yeah, bear with me. What I might do is, if I just stop sharing my screen, it might be easier if we pop it in the chat, in which case, because I don't know why it's not, because it's got volume at this end. Told you this is where I share my distinct lack of capabilities.
Heidi, would you like me to play on my laptop?
If you can, if it shares the volume at your end, because at my end it's telling me it's sharing.
We love a bit of a technological drama.
Well, it just wouldn't be the same without one, would it, really?
I'll pop it in the chat just in case for anybody as well.
Natasha, are you going to share it?
Yes, I'm just doing it now.
Thank you.
Yeah, talk amongst yourselves.
Could you hear that?
No.
No.
How about we gloss over that bit?
Yeah, I'll just talk. People can watch it and I can pull the examples because I've watched it that many times. When I've delivered the training, we'll be all right. Can we?
Sorry.
I'll reshare.
No worries. Thanks, Heidi. So basically, in the video, this. Oh, there we go. Who's got that going?
Sorry, I did. I don't know how to share though.
We'll talk. We'll carry on. We'll gloss over
We'll
it.
carry
People
on.
watch it in their own time.
Okay.
Yeah.
Sorry about that.
So basically, when we break down clear, if you watch the video, there's four different people. They're living with dementia in the care homes. And one of the biggest things is, like Heidi's already said, is understanding the person that you're dealing with and who you've got in front of you. Now, cognition is one part of it. You know, some patients are orientated to time and place, others aren't. But, you know, you can orientate people by the environment, like Heidi suggested. You can help with attention, try and engage them. You've got to think, you know, all of us have been around toddlers. If you show them something and they're not listening or looking, then you change it to something they're going to look and listen at to gain their attention, to gather it through. One of the biggies is communication and language. You know, we live in a multi-diverse area in Bradford, and unfortunately, not all of us speak multiple different languages. For instance, I had a wonderful client who was in a local care home who spoke Serbian. And she would constantly hit members of staff for no reason. She just used to hit them, but she was speaking in Serbian. And eventually I asked the nephew, who also spoke Serbian, to create a leaflet with lots of big diagrams and pictures so that she could point to what it was that she was asking for. We turned out the reason that she was hitting the staff is because she wanted a piece of cheese. And nobody was getting her a piece of cheese. So, you know, she was very happy once we had this leaflet. She was trying to gather the attention of the staff and trying to communicate her needs. She wanted a piece of cheese. And then by showing it on the leaflet, she was able to get a piece of cheese. So people were meeting her needs better. So that agitation and aggression that was being displayed to us as a problem actually wasn't a problem. She just wanted a piece of cheese. And to be fair to her, when I'm in my 70s, expect that from me, because I will also want a piece of cheese and red wine. Don't forget the red wine. In terms of language as well, a lot of dementia, we revert back to our mother tongue. So if English is not our first language, then we will lose the English language and we'll revert back to our original language. So it's being aware of that and making sure that we preempt ready for them to change back to their original language. In terms of the memory will continue to decline in short term. Long term, they will still have for a lot longer. And it's about trying to gain their understanding of their long-term history, pull it together, talk to them about what they did as teenagers, what music did they like to listen to, where did they used to go, what did they like to do for fun. And then the other two that are on there are delusions and hallucinations. Now, not everybody with a dementia will suffer from a delusion or a hallucination, but some people do. Specifically more hallucinations. People will have visual hallucinations or auditory hallucinations. And these can be normally around vascular, Lewy body's dementia, and then obviously when, like Heidi's already touched on, when people have got delirium, so when they've got an infection, a UTI, or a chest infection, they're more likely to have hallucinations with these and say that they can see people who aren't there. Your next bit is your life story and personality. You know, previous occupations is massive. And one of the reasons that previous occupation is a big one is because you might have somebody who worked nights nearly all their life who's now coming to the care home, and that care home are like, they won't sleep on a night. Well, they're not going to sleep on a night because they're an ex-nighttime shift worker, and our body clocks and our circadian rhythms will revert back to what we used to do previously. So you're not going to get them to sleep. So of the ones that I've had in the care homes and I've been in and done the care plans, it's about looking at what can we set up for them during the night. If their body clock is they're sleeping during the day and up during the night, then we have to work around that. How do we change the medications so that they have a morning, a lunch and an evening during the night? Make sure that the chef prepares the food so that they can have breakfast when people are having tea. They can have lunch during the night and that they can have their evening meal before they go to bed. Making sure that the bedroom isn't near the lounge, move it away where they're not going to get disturbed. You know, if that's what their pattern is, join in with that pattern rather than working against it, because all you're going to come up against is agitation and aggression. Your next bit is about the roles within the family. Every single one of us here on this call has more than the one role of coming to work. We have families, we have, some might be football coaches, gymnastic coaches. We all have different roles within our personal lives, and that doesn't disappear just because you've gone into a care home. So it's about how do we fulfill those roles for them people that are in the care homes. And a lot of that is about what we've already said is the distraction techniques, but using something that's going to work for them. We all have probably been into care homes and seen they're all playing bingo. That is like my biggest bugbear, because you're asking a load of dementia patients to play bingo and they're all going to get angry with one another because, you know, Frida sat in the corner has just got a full line, but actually she's not got any of the numbers, but what she thought you said was all them numbers. So you're kind of creating some agitation. So I'm trying to help the care homes deliver activities and distraction techniques that are going to help our patients be happier in them care homes. Personality is a big one. Personality does change when we get a dementia diagnosis. You know, I've got some really exciting examples of people whose personality have changed. And it's being aware that sometimes people can come across as more cross and angry, but that's just because of their personality. That's not that they're just agitated and aggressive because of the situation that they're put in. So being aware of somebody's personality is massive. Some of the others on there is your hobbies and interests, which we've touched on, and likes and dislikes. And each person is their own person. Not everybody's going to like the same thing. You know, having Vera Lynn blasting out for everybody in the care home isn't going to be everybody's cup of tea. And generationally, in 5 years' time, that is not going to be the music that the people in care homes are going to to listen to. So we're trying to promote the care homes to be more sustainable in the future when we're delivering the clear as well. Start thinking about what's going to come next, how you're going to work to that. Coffee machines, that's a big like and dislike. You know, most of us now in our generation have a coffee machine or like to go to Costa, Starbucks. I'll do a disclaimer, there's lots of other coffee places available, but we're not used to having instant coffee. Most of us will have a decent cup of coffee from a coffee machine. Care homes at the minute are still serving instant coffee. So me, for instance, going into a care home, I won't want an instant cup of coffee. So I'm trying to get the managers and the area managers of these care homes on board to understand how they need to develop the care homes ready for the next generation to come in. The next bit is emotional and physical well-being, and physical health and their history is massive. You've got to be aware of what's going on physical for them. It's not just they've got dementia, and you will listen to a guy called Barry who is on that video who explains this so well. People are more than just a diagnosis. And just because they've got dementia does not mean that their physical health wavers off into the distance. Their physical health will affect their dementia, and it's being on top of that. Infection and pains, massive. Looking at constipation, dehydration, all of these cause deliriums if they're not sorted. Medications, interactions between medications will cause delirium. For instance, in terms of a dementia diagnosis, if your patient gets a delirium, it will change their cognition by 6 months. So they will deteriorate 6 months from a delirium. If they end up having an anaesthetic and going under general anaesthetic, it will change it 9 to 12 months and decline it. And that's why we have these conversations with general practitioners of, do we put these patients through a general anaesthetic? Mood. Now, if they've had a mood disorder previous to a dementia diagnosis, that mood disorder doesn't go away. That mood disorder is still there. So we have to look at how can we help their mood? What is it previous to their dementia that used to help their mood? We can still do that just because they've got a dementia. Anxiety is another one. We need to look at how we can help them to feel safe and secure and have a sense of belonging in the care home. And, you know, that comes to the life story bit as well. Activity and environment, looking at a patient's typical day, looking at activities of daily living, keeping them involved. I mean, a lot of us know this, the privacy, the signage, looking at overcrowding and looking at noise. Everyone has a generalized idea that if you live in a care home, you want to be with everybody else. You want to sit in the lounge and you want to be joining in all the activities. That's not individual to everybody. That's another generalized statement. You might have the pet people come in with a load of cats and dogs. You will have people in the care home who don't like animals. So you need to put something on for them somewhere else. Because if you leave them in the lounge and the pets come in, you're going to end up with an agitated resident in your care home. Same with the music man. That might not be for them. They might like it quiet. They might just want to read the newspaper or be read the newspaper by somebody. So being engaged in something that's meaningful to them. And finally, looking at relationships. Now, relationships with family are key. And for a lot of patients, their family is their biggest source. The problem is sometimes these relationships with family can also be quite distressing to the patients. And it's more about how we learn to behave around that person with dementia. And I think that's basically all of the clear. So what we go in is to go and check the behaviour charts. We teach and help to create where the staff are finding patterns within the behaviour charts. And then what can they do individualised to that patient to help that patient? In terms of a couple of case studies, we had a lady who was constantly aggressive every single morning apart from a Saturday. We highlighted it on the behaviour charts and showed, look, she's fine every Saturday for the last 4 weeks. Why is she aggressive every morning apart from that Saturday? And it turns out it was a different worker. And what the worker used to do is come in and put the radio on and chat to her and sing with her while getting her ready. So we took that for everybody else to use. So then there wasn't that agitation in the morning and that aggression when she was getting ready, because she enjoyed listening to the music. She enjoyed talking and singing. The other bit of a patient we had was every time after lunch, they were really agitated, pacing, very, very angry. And when we looked at it, this patient was incontinent literally just after lunchtime. So they were getting upset over the fact that they'd not been able to find the toilet and then been incontinent. So we got the staff to prompt the resident to where the toilet was, and are you going to the toilet? Here's the toilet. As soon as we started doing that, that behaviour disappeared because they weren't distressed because they're not being incontinent. It's just the person-centered care. It's that individual self. And that's what we're trying to deliver with the Clear. And now I'll pass you back to Heidi. Now I've rabbited on for the last, I don't know how long.
So what we're going to give you now is a bit of an overview of the services that can help. So within Bradford District Care Trust, we have the Care Home Liaison Service and the Dementia Outreach Service. They are actually two separate services, but do work very closely together. So I think a lot of people on the ground floor actually feel that they're just one service. But Care Home Liaison only consists of 3.5 full-time nurses, and they have one advanced nurse prescriber to cover the district. So that is all of Bradford, the Airedale and Wharfdale valleys, and the Craven area. They have 15 care homes under them within Craven, 37 within the Airedale and Wharfdale valleys, and over 64 within the Bradford area. There's over 4,500 people residing within these care homes, and they work Monday to Friday from 9 o'clock in the morning till 4 p.m. They're not a crisis service. An urgent response can be within 48 hours. Routine work can take up to 6 weeks, and that is when everybody's in work, fit, well, and healthy. And like I say, 3.5 nurses to cover that many people. It's a small service offer, but they do have quite a big impact for that. They work with people that are living within care homes that have a mental health condition. So that does include dementia as well as functional mental health conditions such as schizophrenia, bipolar disorder, depression, etc. But that is ultimately their referral criteria. They've got to be within care homes. It's got to be a mental health condition. Otherwise, it's signposted out to the physical health arena. They support with discharge to assess process as well through advising trusted assessors on appropriate care settings, and that is to try and minimise people going to a care setting that isn't appropriate to their needs and that discharge to assess placement breaking down. The Dementia Outreach Service, they have 2 full-time nurses and again one advanced nurse prescriber to cover the district. They have 1 Band 4 trainee nurse and they have 2 full-time healthcare support workers. So overall they have 6 staff, but the number of qualifieds is significantly reduced. And they work Friday to Monday, so they do 9 a.m, 9 p.m. And their role is to provide that crisis intervention work and support, transfers from the dementia assessment unit, but also do that admission avoidance and gatekeeping process. It's very much to support the out of hours admissions into the dementia assessment unit and try and sort of minimise those admissions, because we do know that people with dementia, every transition, the dementia deteriorates and the cognition deteriorates. So for them, the key referral criteria is about supporting people within either their own homes or within care homes, but all referrals must have a diagnosis of dementia. So again, they work not just across those care homes that we mentioned, but also for people residing in their own home. And again, they work across all of the Bradford and Craven areas and Airedale and Wharfdale. So what can they actually do? Now we've told you what the service looks like. They can offer proactive work, so they can work with specific care homes, families, carers, as to where people need extra support, helping to identify some of the things that we've talked about previously as to why behaviour is presenting as distressed. They can deliver clear and dementia awareness training. They can support with signposting to appropriate services through safeguarding, palliative care, through the digital telehealth hubs. They can help understand behaviours which are challenging and support with that care planning, identifying what the care home needs to do and how best to manage these behaviours, be it music on a Saturday morning, and singing to somebody rather than it just being a Saturday morning thing, or be it actually this may not be the right environment, do we need to consider alternatives? They will liaise with GPs, community mental health teams, and other services involved in the individual's care, providing advice and recommendations. And from a reactive point of view, they are able to assess, diagnose, and problem solve and prescribe medication, advise on care planning in all in one visit, and they can make a huge difference to those individuals and care home residents and support some of the key indicators within those NICE guidelines on how secondary care supports people living in care homes. They can support with help seeking alternative placements if required and through advising on more appropriate settings, and they can signpost to those who to contact and how to achieve this. They can escalate concerns through clinical commissioners and where appropriate if needed to protect an individual. And the rest are just references. What we would say is within both the care home and the outreach service, they are very good at coming in and doing the reactive work and do that. That does take up an awful lot of their work. We are moving care home liaison to try and get back into a more of a proactive work now that we've got the outreach service to provide some of that reactive work. And one of the things that we're sort of looking at is that referral criteria of actually what is the referral about? Is it about behaviours that challenge, or is it that we need medication? And that if it's medication, have we looked at the behaviours that challenge and the rationales behind that as a first port of call rather than just straight to medication? But ultimately, that if we have tried care planning, those behaviours that challenge, if we've tried medication and it's still not working, is it support to look at appropriate placements? And I'd say that's very much sort of the key areas of what those two services do. So I think I'm going to stop sharing